I'd like to thank two of my colleagues, Niels van den Donk and Francesca Guy, that earlier in the year have accepted to kind of chair a series of review on myeloma. And I was then given the title, what is the role and what is the perspective and what is the impact of novel immunotherapy, particularly anti-CD38, naive immunotherapy, daratumumab, isatuximab, but also other immunotherapy like elotuzumab, anti-SLAMF7, but in the context particularly of non-transplant eligible patients, and particularly upfront. So it's interesting. So I have 3 minutes, but I'm not going to summarize entirely 10 pages in 3 minutes. But overall, I think what is important to remember here is that it's incredible that 15, 20 years ago, it was obvious to everyone that transplant-eligible patients had immensely benefit from the treatment before, after the transplant, etc., but not the non-transplant, because it was so difficult to improve the non-transplant not being exposed to a transplant. And it's incredible to see 20 years later how the non-transplant have really benefited from an incredible series of great groundbreaking improvements, novel drugs, novel combinations, novel understanding of what was this population. So first of all, to remember, now it's a very heterogeneous population. And if we want to make it simple, you have the frail and the non-frail. And you will not treat the frail and the non-frail the same way, not anymore. And you will not have the same objective for the frail and the non-frail. Globally, you want to control the disease, you want to have a deep response, a good quality of life, and you know that improves the survival. It's much more difficult in frail than in non-frail patients to reach these objectives and to transform to score. So for non-frail fit, we have moved from melphalan-prednisone combinations, bortezomib, melphalan-prednisone being the best, and we have added daratumumab to it, Alcyone study. Very interesting data, incredible data, improving by month the PFS obtained with VMP when you add daratumumab. However, VMP remained a limited in time combination regimen, and that is its primary limitation. So you only continue daratumumab single agent as a kind of continuous treatment / maintenance, and we have seen the limitation of this. But it was an improvement to VMP, and in certain countries that will only have access to VMP, it's great if the patient can be treated with VMP plus daratumumab. However, over the time, we have seen that another backbone, Revlimid dexamethasone, was possibly much easier to combine to, and the benefit when you combine to Revlimid dexamethasone were much greater. And that is initially VRD, but on top of VRD, anti-CD38 Revdex, Maya, daratumumab, Revlimid dexamethasone, where the median PFS is going to probably reach 5 to 6 years without transplant, 45% of the patient being older than 75 years old, and this has never been seen before. Still, how can we improve this? Well, the idea in the next future, for the next 2-3 years, is to see if we can test a quadruplet combination where either the backbone is bortezomib Revdex, to which you add an anti-CD38, daratumumab, CEPHEUS study, isatuximab, IMROSE study, readouts around 2023, or you start with dara Revdex or isatuximab Revdex, to which you add bortezomib, and you question whether, if you have the best backbone, can you improve it by adding proteasome inhibitors, and which group of patients is going to benefit best? Dara Revdex plus minus bortezomib is a US academic study from the SWOG group, and for the isatuximab Revdex, to which you add bortezomib, is done by the French IFM, Intergroup Francophone Multiple Myeloma study. It is called BENEFIT. And so all these studies will let us know which patient can be for drugs, which patient should be for drug, and what is the role of PIs. Now, for the frail, we still believe the addition of immunotherapy, particularly the anti-CD38, is absolutely key. The question we ask now is, what is the best, if you if you pick daratumumab or isatuximab as a backbone, what is the best partner? Keeping in mind that you are in frail patients, you absolutely want rapid activity, zero tox, immediate improvement in quality of life. And so for these patients, there are tests with Revlimid, there are trials with ixazomib, keeping in mind that the more you are ambulatory or oral, convenient, the more you're going to improve the quality of life of the patients on top of improving the myeloma path. We also, so that's Ixadera is done by the Dutch, the RevDara is done by the French in a study called IFM 2703, where the question is, we know Dara-Revdex is incredibly effective. Can we put daratumumab sub-Q? Can we drop dexamethasone, having only a doublet Dara-Rev? And we have a phase 3 randomizing Dara-Rev, no dex, Dara sub-Q to Revdex, where for frail patients above 80, where we really hope that we are going to demonstrate incredible results, putting forward the importance of the immunotherapy and the importance of the immunotherapy to the frail patients, where we know that the options of treatment are still very limited. So it's obvious that immunotherapy has transformed the field of myeloma, including the non-transplant eligible, including the very elderly patients. And it's obvious that it's only the start. The future is going to see even more progresses using the immunotherapy in myeloma, and including in the non-transplant eligible patients.